Welcome to the Executive Innovation Show podcast, where we bring you real executive conversations with industry game changers and thought leaders. We ask the questions you're thinking, what you're scared to ask, and we make your brain hurt afterward. With your host, Carrie Chitsey Wells, co-founder and CEO of One Touch Video Chat, live video interviews, and the nonprofit Humans Helping Humans.
Hello, everybody, and welcome to today's podcast. We have a great podcast today. We're going to be talking about best practices and Medicare Advantage, a full risk primary care model. I have a great guest with us today. He's a physician, an advocate, a business and thought leader, the chief medical officer at ChenMed, Dr. Gordon Chen, who plays multiple roles in the growing physician-led, full risk, outcome-based medical practice that is transforming healthcare with the neediest population. Dr. Chen, welcome to the show.
Thank you so much for having me, Carrie. Happy to be here.
Well, awesome. You guys are just doing some amazing stuff, and we're going to be talking about a bunch of best practices today and how you kind of got to the full risk primary care model, which I think is really amazing. But I want to start with the backstory because you guys have a pretty interesting cool family backstory at ChenMed of why it was started. Can you tell us a little bit about that?
Yes, I'd be happy to. You know, we have an amazing backstory. Before diving in, I do want to create more awareness initially into just this crisis that we're having in American healthcare today. And we've got increasingly high costs. We've got rewards for sick care, rewards for complications, and complexity. And so there are families all over America that every day are feeling the struggle, and they're suffering through this poor coordination of care and this living in this fee-for-service world. And you know, fee-for-service drives volumes and procedures. And now back to our story, we were one of those families that were suffering through the confusion of the current healthcare system today. And, you know, I come from a family of physicians. My father is a physician. My wife, my brother were all physicians. And 15 years ago, my father was diagnosed with a terminal cancer. And he was told he had 2 months to live. He had this mass behind his nose. And as a family, we thought we were going to lose him. We were struggling to fight for his life, to figure out you know, what was his diagnosis? What was the treatment? What were the treatment options? How could we band together as a family and help him through it, and maybe just help him live another, you know, month or two? And we're so fortunate that his initial diagnosis ended up being a potentially treatable and curable form of lymphoma. But we had about 6 months where we struggled. We went to the ER. We had complications. We were literally fighting for his life. And we spent a lot of time, you know, on our knees praying for him. We spent a lot of time just, you know, figuring out how to get our doctors to communicate better. And we said to ourselves, if we're a family full of doctors and this is happening to us, imagine our patients. You know, we're taking care of seniors, some of the oldest, sickest, poorest patients. And we're thinking, scratching our head going, how is it possible? How are they making it through this broken system? And as we were suffering, we were thinking, we need to create a better healthcare solution for them. And so the wheels began to turn in our family, and we developed this burning desire to say, we need to make this right. We need to flip healthcare on its head and make things back from the patient's perspective and with a focus on health and wellness rather than uncoordination or complexity or complications. And so that's what inspired our family to kind of journey forward. And thank God my dad is alive today. He's still working full time. And it's really given us this heart to all work together as a family and all just understand where patients have come from, and then take that back into our, you know, the healthcare world and of being doctors and administering care. and really having us bond together and say, we can fix this. And the snowball started to develop, and with one center, two centers, three centers, and we started to grow and saying, hey, we can actually solve a tremendous need in healthcare today.
So that's an awesome story, and obviously a great business story as well, as to how do we impact change and banding together, and being kind of having a similar story of doing that with my dad, and him having a stage 5 renal failure. You're spot on in that the healthcare system is broken, that it is it's a full-time job, not only as a patient, but as a caregiver, to try to figure out the care and demand answers and, demand better. So kudos to you guys. And now you're at, you started this kind of was the turning point for you guys. And now you're, 50 primary care medical practices, which is really large for primary care. But you've made the transition to go full risk Medicare Advantage, which is pretty risky, ballsy, whatever you want to say. But it's pretty awesome. And, tell everybody what that means. We get a lot of questions from medical professionals of what is really, the full risk model and kind of how that works. And I know it's, if done right, it affects and has some amazing patient outcomes. But what got you guys to make that transition, and tell everybody a little bit what that actually means?
That's a great question, Carrie. So full risk, before I get into full risk, fee for service is just getting paid for every encounter, regardless of the outcome, as long as there is a billable encounter that's submitted, then a provider will get paid. That's fee for service, right? As you transition to full risk, the payment is can be substantially more, and the payment is upfront, and it's by the patient and by the amount of disease burden that the patient carries. So let me try to simplify it a bit. If you think of the whole healthcare funding as a whole pie, and let's say primary care, for example, is a very, very small sliver of that pie, that's what primary care docs have access to. In a full risk model, the primary care that is at full risk has access to the whole pie. It has access to Part A costs, which represent, hospital fees, or Part B costs, all the professional fees, and Part D costs, the drug fees, right? And so once you have access to that whole pie, then you think, how do I simplify my approach so that my patient experiences the best health, the best service, the best outcomes, and for the lowest cost? And if you can save where there typically is waste, then you can reinvest it back into primary care, into prevention, into getting upstream and being proactive to the care. And so that's what it means to be full risk. It means you have access to the whole pie. Now, the flip side would be if you don't manage your patient's outcomes well, or you can't bring them to better health, there is a potential that the costs exceed what you have, because healthcare costs can be quite high. And so there needs to be a lot of thought and strategy and technology support and process in place to help to decrease some of the risk. Now, we started with full risk with just one center. And so now we're approaching close to 60 centers by the end of this year. And as we've grown centers, we've just stayed laser focused on a full risk model, meaning right out of the gates, our providers have 5 times less patients to take care of compared to the typical primary care physician. So instead of 2,000 or 2,300 patients in a primary care panel, it's about 400 to 450. So we're setting them up for success. We're creating the accountability from that primary care provider standpoint to help meet all of the needs of the patient as much as they can, and help prevent all of the avoidable hospitalizations that they can prevent. Now, if they can do that well, then there's plenty to reinvest back into primary care. And so how do we reinvest? We reinvest into the smaller panel sizes, into giving more of our primary care providers the support they need, the care team that they need, the transportation that their patients need, the on-site medications that they need, bringing in the key specialties on site to make it easier for patients as well. And then think of the whole healthcare system aligning around what the patient needs to get better outcomes. And if there's singular focus on helping the patient achieve better outcomes, then there's plenty of funding to actually meet those needs and to deliver a better outcome. And that's what we've done at ChenMed, and it's allowed us to reduce hospitalizations by 40 to 50%.
That's awesome. So I want to back up and ask some questions on the model. So you talked about the patient ratio. So, typically, 2,000, 2,300, you've reduced that down so you can hire, your doctors and so forth are having better relationships with the patients so they can affect the outcomes versus, being completely overloaded with too many patients and not having that personalized relationship. Let's talk about the patients for a second. Are you serving just any Medicare patients that have Medicare Advantage, or is the cost for the patient higher, less? Like how is, a patient that's coming into one of your locations, how is it different coming into your location than it is coming into, Dr. Jones' primary care office?
That's a great question. So, at ChenMed, our mission is to honor seniors with affordable VIP care that delivers better health. And oftentimes these words affordable and VIP care, like next to each other, don't really make sense to a lot of folks. Right? And so you that's right. You hear about these concierge practices that deliver VIP care, but make patients pay a premium for it. And then that tends to cater towards, the wealthier patients, leaving the ones that, the poorer patients, leaving them behind. And so at ChenMed, our mission is to meet the needs of the old, the poor, and the sick. And so in a full risk Medicare Advantage model, patients pay very little. It's typically $0 premium for them. They typically don't have copays associated with primary care, very low copays with, with specialty care and with tier 1, tier 2 medications. And so that affordability, we really try to make real to the patient. And so we can go into neighborhoods that have typically been forgotten, where folks are not building primary care centers in. We go into those communities, they can sign up for a Medicare Advantage plan that we have a full risk relationship with, and then we can start providing them with VIP care out of the gates. Okay.
So that's awesome. So the next kind of step is, everybody's used to, for the physicians that listen to the show, as well as just, patients or caregivers, typical primary care, you go in, it could be a practice of, 2 doctors or, 50 doctors, whatever it is, right? You go in, there's a typical waiting room, you schedule your appointment, and then, you might get referred out to, cardiology. You might get referred out to get some other testing to, different specialty doctors, things like that. You're doing your wellness checkups. You go in if you're, sick, things like that. Tell me, walk into the door of one of your full risk. You brought in some specialty medicines, other, doctors and stuff. It's not just primary care. Tell me how that experience is different than the standard primary care.
Great question. So Carrie, when a patient comes in, this is not your typical primary care doctor's office. All right. So we have these medical centers that have lobbies that patients feel like it's like a community center. It's part of their community, and it's a place where they are comfortable coming on a regular basis. They can get coffee, refreshments, healthy snacks. They can be greeted by staff that know their name, that see them regularly. And then the key difference is when they're meeting with their primary care physician, that is not a typical relationship with a PCP. That's their health coach. That's someone that is going to partner with them and say, how can we achieve your best health? And it's not just the medications or the specialty visits or procedures that can be done, which drives sick care. That's the current fee-for-service model. This is actually taking a look at the patient as a human, as a person, and saying, what can we do to help you to achieve better health? What does that look like? And let's start with coming out with the highest goals that you would want to achieve, whether or not it's, living to a certain age, or getting off medications, or getting to a certain weight, or being as functional as you can be, or living the best years of your life, with the least amount of pain or discomfort. Whatever it may be, the primary care, our PCPs are the quarterbacks of their care. And the goal is to help them achieve better health than they could have otherwise. And so once that occurs, then you think, oh, the whole relationship is different. It's not just a PCP listening to and reacting to current active issues. Maybe you have to do an initial, you have to do some of that initially to get the blood pressure stabilized, or patients on medications for diabetes or heart disease or whatnot. You're optimizing that, but then it's thinking ahead. How do we get you to even a better level of health? So a patient of ours, because we tend to see our patients frequently, and I was discussing with one of my patients that they're introduced to the model, and when they initially didn't understand what it was like, they didn't get why they wouldn't need to come in so frequently. And they said, well, I'm stable on all my medications, and I had an opportunity to level set with the patient, say, listen, what are your greatest goals? And she said, I would love to live to 100. And she was in her late 70s. And I said, well, if you want to live to 100, that's a great goal. But we have a lot of work to do. We need to let's review your diet. Let's review, how much exercise you're doing. Let's review your social support, how you're managing stress. And then also on top of that, of course, we're going to review your medications and get you additional help and services that you need to address those active medical issues. But let's get you to live to 100 healthy and happy.
Right.
If that's your goal. And let's meet frequently to check in on how you're doing with that goal. And I'm going to do the best I can to help you to achieve that. And so that's just one example. Other patients, it's remarkable. You ask them, you say, hey, what are your goals? And, I would love to get off insulin. Wow, what a great goal. And so your treatment strategy and your engagement completely changes to want to establish these great goals. And as health coaches, we can help walk them along that path to achieve the goal.
So that's great. So the next angle I want to talk about is, running an organization, whether it's, in the medical field or without, you have to, top down be incentivizing your employees for, the individual goals. And being a full risk model, it's very different hire when you're hiring, physicians in a full risk model than you're hiring a fee for service. And so the way that you're, measuring and bringing on doctors is a completely different conversation of, this is how much we're looking, bill and patients and things like that. So tell me a little bit, how it works for, your providers that work at ChenMed, that, how is that experience different, and how do you incentivize those physicians to spend that time to, not get the penalties, to really proactively manage the patient care and outcomes?
Yeah, that's a great question, Carrie. So at ChenMed, we really, we want the best of the best primary care. and folks that are mission driven and believe that they can heal patients and that they want to have deeper relationships with patients. So right out of the gates, we're selecting PCPs that want a deeper impact with their patients and want to be a part of this overwhelming change that's occurring in healthcare today, in outcomes-based medicine, value-based care, and they want to be a part of this winning team. And we want them to not only have fulfilling purpose in the impact that they're having on their patients and community in America, we want them to have great personal opportunity as well. And so typically our PCPs will have very competitive base compensations right out of the gates. But for us to attract the best PCPs and retain them, they've got to have great upside potential. And then we've got to tie that upside potential to patients winning. And so when their patients get better outcomes, they win as well. And their care teams win and their centers win. And so it becomes this like beautiful situation when they're able to heal their patients, then everyone in the center also wins as well. We're trying to create that win-win. So ChenMed is a place where primary care providers are fulfilling purpose and they're also fulfilling personal opportunity as well.
Yeah, that's great. And especially, younger physicians that are coming out, and as you look at the millennials that are very, all about philanthropy and giving back and making an impact in the world, as you're looking at that demographic that's maybe coming out of medical school or been practicing in another practice for a while, I can see that being very attractive versus a fee for service model when you're recruiting medical professionals, whether it's, PAs, MPs, or physicians coming into the practice, that they truly can make an outcome and feel like they're doing good, but still be compensated and not kind of be in this fee-for-service hamster wheel.
That's right. I mean, they're finding mission-driven folks, particularly, millennials coming out. But, I truly believe that folks go into healthcare, they go into medicine because they want to make a difference. So I believe that it resonates with them to truly have that mission-driven component to help people. But then folks have a ton of loans that they need to pay for. They're starting families, and so being able to be in a situation where you can have that purpose component and also have the opportunity component is a great, I think, win-win for PCPs. Right. We need folks that are willing to learn and are hungry to learn a different approach to medicine, because in medical school or in training, most of that training is still based upon a sick care approach. It's right. Not based upon achieving better health or health coaching or being accountable for outcomes. And so, at ChenMed, we've designed, recognizing there's a big training gap with new providers coming on board and how we practice. We've designed, about a year of an intensive training program, which we've called Black Belt training. And, there's 7 different levels of the Black Belt training, and they achieve their Black Belt when they're able to demonstrate that they can improve the outcomes of their patients. And so, yeah. I'm sorry?
Six Sigma Black Belt model.
We've got more levels in the Six Sigma model, but you can think of it as Black Belt training for outcomes-based champions. Nice. And those folks in our organization become partners, and there's great recognition, prestige, and opportunity that comes with that as well.
Awesome. So the last thing I want to talk about is, when you go full risk model, obviously you have to have very good operational efficiencies. You have to figure out and kind of be up to speed on the latest and greatest in digital healthcare technology, whether it's remote monitoring, whether it's video telehealth, to make sure that you can still drive that, as you said, kind of concierge type medicine, but do it not only having them come into a physical location, but being able to, drive convenience for your patients while still providing that proactive care. Tell me, where's the kind of future for ChenMed of being able to have these operational efficiencies? Are you guys, whether it's remote monitoring, you mentioned transportation earlier, telehealth, how does those kind of putting in some of that digital technology provide your physicians kind of more proactive care, but doing it in a digital manner to help drive down some of those costs, but not lose sight of the patient experience?
That's a great that's a great question that you're bringing up. Technology is a big deal. Technology can be an enabler, or it can be a barrier, quite frankly. And in our organization, it's a tremendous enabler. We have our own technology arm called CTech. We have our own practice management software and our own EHR, electronic health record system. And we designed that around the needs of our PCPs and our physicians. And it's created by physicians, for physicians. And so it's really become an enabler, and it's allowed us with, being full risk, you need to have a lot of data and know where, where you're either at risk or you have opportunities in terms of improving patient outcomes. And so anyways, technology is critical. Each of our PCPs, they get their own, iPhone, and patients have access to the iPhone as well. And we have all of this technology that helps to enable, HIPAA compliant communication, and then multiple frequent touch points with the patient. So, I do think that having that face-to-face encounter, at least initially, to develop that trust is really important. And then supplementing it with telehealth and supplementing it with additional, touches or communications, even while the patient's at home, can be a great advantage. So patients, they oftentimes they text us, they email us information, or they call us when they need help, and we want to be there for them. Being in a full risk model, we have to have operational efficiencies so that the clinic flow is smooth and patients aren't waiting for a long time. But then we also have to build in some flexibility, because we need to be there when the patients do need us. I think in terms of telehealth and the opportunity for video remote visits, I think that could be huge. It could be huge for a few reasons. For one, if the patient isn't able to come in for any reason, then we can still get them either on audio or audio and visual at home. That could be a very impactful visit that drives better health and outcomes with the patient, and certainly builds trust. I've noticed when we proactively reach out to patients and see how they're doing and to check in on them, even when they're at, in their house, it generates tremendous trust. The other thing that we're looking into is, I think there's a great opportunity for load balancing. I mean, we haven't gotten there quite yet, as an organization in terms of figuring out the perfect way to load balance. But if if there's one center that has let's say a lot of visits, or even unscheduled visits or walk-in visits, and there's another center that they have capacity to figure out how they can to help to load balance, I think that could be another great opportunity. And lastly, primary care, we are built upon primary care and access to primary care. There are some key specialties like behavioral health where there's even further shortages, in America. And telehealth could be a great opportunity to both provide, specialist to PCP consultation, and also specialist direct to patient consultation in their homes, in places where they otherwise wouldn't have access to that specialty care. Does that make sense, Carrie?
I think that's great. And I think the last thing of what you just said, we're seeing too a lot of, of these primary care that are being this, centralized kind of hub and spoke, right? And so your primary care, even for the folks that are coming into primary care, being able to connect them while they're there to specialists versus them having to now go off and go to, 3 or 4 more appointments, especially when you're talking about baby boomers and, that transportation may be an issue, or maybe, a caregiver's involved. And, it's so complex when you talk about chronic care patients who already have a significant amount of doctor's appointments. If they can get, or in their primary care, and maybe they can get their, diabetic eye exam really quick in primary care, connecting through an ophthalmologist, or maybe they can connect to a dietitian, or like you said, a mental health professional, and they can do it in the comfort of primary care and video connect, and be there with a nurse or whatever. We're starting to see a lot of that too, of making that so the patient doesn't have to then, the no-show rates continue to go up as patients get older, and, there's transportation issues, and, caregivers are having to get off work multiple times to take mom or dad to appointments. And so I think we'll start to see a lot more of that, of primary carers who are really trying, even ones that aren't on full risk model, trying to be more that hub and spoke for patients, to really, make sure that they're making those appointments, which, is driving outcomes as well.
That's right, Carrie. Primary care and is that connection point for patients, because healthcare is very complex. It's like speaking a whole new language, and there's all these complexities in it, and we need simplification. Right. And so primary care needs to be that link, that trusting quarterback of the patient's health, and need to be able to connect that patient seamlessly to wherever they need to go, and then to provide as much of the care they can themselves. And tools like telehealth or remote monitoring or on-site specialty care, or these things can help to empower primary care. But it's very clear to me that primary care is the future, and it's the reason why groups like ChenMed, that we're able to grow and expand, and there's the demand is tremendous out there. I mean, we're in 8 states and in going on 14 different markets, and the demand continues to be tremendous because patients need this type of care. They want it. They want simplicity. They want someone to be accountable for them. They want, like a physician, to have that feeling that you have a physician in the family that is doing everything they can to help. And so I think that's not only just the future, that's what we're seeing now. That's what we're seeing today, and it's growing rapidly.
Well, you guys are doing an amazing job. I want to thank you so much, Dr. Chen, for being on the show. To continue to follow ChenMed, go to chenmed.com, socials at ChenMed. Go see what they're doing. They're doing amazing stuff. They are leading the way and defining the best practices in the full risk model. And we will continue to follow your journey. Dr. Chen, I want to commend you guys for really paving the way and leading the way here, and just really making a difference in patient outcomes. So thank you for all you guys are doing. We'll continue to follow your journey, and thanks for being on the show.
Thank you, Carrie. Thank you so much for having me on the show, and appreciate all of your support.
Well, great. Please leave any comments you have for myself or Dr. Chen. If you have any questions, feel free to share the episode. Click on the links in the show to learn more about ChenMed and learn more about what's going on in digital healthcare. This concludes today's show.
This podcast has come to a close. To hear more from the Executive Innovation Show podcast, subscribe, submit questions, and share the love. Follow us on social. We're everywhere.